The surgical oral board exam, the viva, tests your capacity to make immediate, safe decisions under pressure. You sit down, and the examiner delivers the prompt. Salem is a 41-year-old man presenting with intermittent PR, or per rectum, bleeding. The clinical data is handed to you in a neat package. A colonoscopy shows a mass at the hepatic flexure. The biopsy confirms a well-differentiated adenocarcinoma. Preoperative staging is entirely negative for distant metastases. Then the examiner looks up and poses the first hurdle. What is your surgical decision? A medical student might stall here by reciting a broad differential diagnosis. The examiner will fail you for that. The diagnosis is already established, and the examiner is waiting for immediate definitive surgical action. This grading rubric shows the exact checklist the examiner holds. To pass this first gate, state a single procedure without hesitation. Right hemicoloectomy. That answer immediately secures 7 marks. It proves you grasp the oncologic necessity and patient safety protocol right out of the gate. The examiner moves to the next phase. What are the preoperative preparations? Rapidly list the physiological controls. The patient is NPO, you insert an NGT to decompress the stomach, and you start IVF for hydration. Each of these lines earns 3 marks. Next, you specify the infection control steps. This requires mechanical colonic preparation alongside prophylactic antibiotics and metronidazole. Finally, you state the non-negotiable medical legal requirement, obtaining formal surgical consent. The psychological trap in this early phase is the urge to rush into the operating theater. Skipping basic ward care, like consent or antibiotics, destroys your momentum. It signals to the examiner that you lack systematic patient care. The examiner states prep and drape are complete. Now outline your initial entry into the abdomen. Looking back at the rubric, you have 2 accepted options for a total of 4 marks, a standard midline incision or a right paramedian incision. Once inside, the first maneuver is systematic abdominal exploration. You inspect the liver and peritoneal cavity to rule out occult metastatic disease. From there, you perform an omental dissection. This exposes the operative field and clears the transverse colon. Operating for oncology is highly specific. It is a rigid algorithm of vascular control and clearance dictated entirely by the patient's embryological development. The objective is to excise the entire lymphatic basin alongside the anatomical mass. This schematic illustrates the right colon and the superior mesenteric artery vascular tree. The first step is the high-tie division of the middle colic vessels. You sever the right branch near its origin and immediately divide the ileocolic vessels at their base. These high-tie divisions are explicitly required for an adequate oncologic lymphadenectomy. The goal is to harvest the maximum number of lymph nodes along the arterial supply to ensure complete oncologic clearance. With the central vessels secured, you outline the sequence of dividing the iliomesentery and the right paracolic peritoneum, also known as the white line of Tolt. Dividing this avascular peritoneal reflection allows you to successfully mobilize the cecum and ascending colon medially, lifting them away from the retroperitoneum. But before you cut or mobilize any further, you must vocalize an absolute critical safety waypoint. You must state that you will visually identify the right ureter as it crosses under the gonadal vessels in the operative field. With the ureter safe, you detail the final step, division of the terminal ileum and transverse colon. You accumulate 24 points here. Failing to explicitly state you will identify the ureter is why candidates fail. Skipping this step signals you are a dangerous surgeon. The resection is complete. The examiner now asks how you plan to restore bowel continuity. You state the 2 acceptable methods for reconstruction, an ileocolic 2-layer sutured end-to-end anastomosis, or an anastomosis by stapling. While the traditional hand-sewn method demonstrates classical surgical skill, mechanical stapling offers rapid, consistent alignment of the tissue layers in modern practice. The examiner then prompts, the ileocolic anastomosis was done. What is your next step? You detail the final mechanical actions to safely leave the abdomen. You perform a washout, place adequate drainage, and complete a layered fascial closure. Completing the anastomosis does not end the operation. Omitting the washout, failing to place a drain, or forgetting the fascial closure bleeds 8 easy points. The scenario now moves from the operating theater to the surgical ward. As seen on the second page of the rubric, the examiner asks for your post-operative care plan. You list the immediate physiological supports that must be maintained, the nasogastric tube and intravenous fluids. You outline the ongoing medical management, specifying scheduled analgesia for pain control and the continuation of appropriate antibiotics. You must state the strict, evidence-based criteria for feeding the patient. Oral intake can only be resumed when there is explicit clinical evidence of returning bowel function. Postoperative questions test a different skill set. The examiner needs to know you can safely manage a patient's systemic recovery alongside their anatomical repair. You then face the examiner's final trap, identifying the common specific complications for a right hemicolectomy. You list the acute, early-phase complications. These include intra-abdominal bleeding and post-operative ileus, where the bowel temporarily stops contracting. Next, you highlight the most feared specific complication that presents in the mid-phase of recovery, an anastomotic leak, where the newly joined bowel sections fail to seal properly. Finally, you list the infection-based and long-term mechanical complications, wound infection, abdominal collection, and eventually an incisional hernia. This completes the 100-point rubric. Mastering the surgical viva requires treating the examiner's rubric as a rigid flight checklist. True consultant-level success is matching the examiner's predefined granularity perfectly. You leave no room for assumptions, and you verbalize every standard of care.